Welcome to another episode of Hoosier Homeland, the podcast that explores the latest news and insights in the world of emergency management and public safety. I'm your host, Bridget Campbell, the IDHS Digital Communications Coordinator, and today we're delving into a groundbreaking healthcare model, reshaping the way emergency medical services work to serve our communities across the state. It's called Mobile Integrated Health, or MIH for short. MIH is more than just a service. It's a patient-centered approach to healthcare, delivered right in the comfort of your own home or through innovative mobile environments. Today we have not one, but two fascinating interviews lined up. First, we'll be talking to Emily Castor, the Mobile Integrated Health Coordinator at IDHS, who will shed a light on MIH at the state level, how it was born in the state, and how these programs are positively impacting communities, and what the future holds for this transformative model of care. Later, we'll hear from a group of dedicated individuals on the front lines, the MIH providers from Bloomington Fire Department. These community EMTs work tirelessly. You'll get to know them in their own words as they share their experiences and insights on why MIH is so important to them. But before we dive into that, let's understand the essence of mobile integrated health and how it's revolutionizing healthcare across the state with Emily Castor.
Well, my name is Emily Castor. I am the Mobile Integrated Health Coordinator with the state of Indiana, the EMS division of Indiana Department of Homeland Security. Before I started this job back in January, I was a certified medical assistant with IU Health in a general surgery and trauma practice. And then before that, I was a medical assistant as well for a urology practice. So majority of my background comes from the hospital side of things, so I enjoy trying to kind of marry the pre-hospital side and hospital side of healthcare.
Can you explain the concept of mobile integrated health and its significance within Indiana's EMS system?
So the concept of mobile integrated health is it's an extension of EMS, and it's trying to kind of cut down on the overutilization of 911, and it goes with the workforce shortage within the EMS system as well. The importance of it is there's a lot of holes and gaps throughout Indiana's health systems, and mobile integrated health is kind of that gap filler position. So it helps us meet the patients where they're at and how we can give them the opportunity to use the resources within their community for their treatment, and how they can kind of take control of that treatment on their own as well. But we're kind of that space filler almost to help them almost take charge of their own healthcare.
I know that MIH is a fairly new thing in Indiana. How has the role of EMS personnel evolved in response to the MIH approach?
I feel like when it comes to like the evolution of all of it, everybody's been very open to the process of, integrating the mobile integrated health side of things. A lot of the personnel that have joined this side, they realize that, there is that need, and I feel like we're still able to use the EMTs and paramedics and all of the other great people that we have working with us. They're not just within the EMS system, but it doesn't change their role, but it puts them in a different position, and they're not just running emergent all the time. They get to kind of take care of that patient, and it's more than just the one-time encounter.
So I know because it is a newer concept in pre-hospital care in general, I know that there were a lot of legislative changes that happened in Indiana in 2019 and 2020 that facilitated the growth of MIH programs. Can you talk a little bit about what that was and how that worked?
So with the legislation changes, they were basically trying to kind of right the role of MIH within Indiana and how they can create this whole different section of emergency medicine and everything that comes with it. So it's like building everything from the ground up. You have to have statutes, you have to have all of these different waivers and so rules, regulations, all of that they had to build from the ground up. So my predecessor, Brittany, helped with all of that. And so now I get to help build on top of everything, like the foundation that she laid.
Can you share some examples of the types of services provided by MIH teams to patients in Indiana?
So one of the bigger things that we focus on is like hospital follow-ups, or if you notice that a patient has been calling 911 for the same thing over and over and over, either a fire department, EMS station, whatever that program is within, they will go check on that patient, see, hey, why is this happening multiple times? Why have you fallen? What can we do to help you? Is there anything that we can add into your home? Anything that we can assist you with that would make this easier so that you're not having these continued issues? They do a lot of OB and newborn things as well, because Indiana does have a really high infant mortality rate. They do a lot of drug overdose follow-ups and diabetic follow-ups, but a lot of the places are focusing on hospital follow-ups and preventing that readmission to the hospital after a hospital stay.
Gotcha. I know since COVID, telehealth has been really it has changed the game in health. I'm wondering, how does telehealth play a role in Indiana's MIH models, and what benefits does it offer to patients?
So telehealth, it kind of offers that new, well, not necessarily new because we've all found that out during COVID, but it offers that face-to-face contact with a provider that you wouldn't always get if you're homebound or you just don't have the access to get to a doctor's office. Mm-hmm. So telehealth helps with mobile integrated health because we can help them get connected to those physicians and or providers and help them with kind of the in-betweens of everything. So like if they needed lab work or something like that and the mobile integrated health team is able to do that, then they can draw labs right there in the office or right there in the home. They can let the physician know like, hey, this is what's going on with this patient because you're the hands-on when the doctor cannot be.
How do MIH programs help integrate EMS into the broader healthcare system in Indiana?
So I feel like it makes patients realize that, EMS is more than just 911. It's more than just, these people that show up only when, the worst of the worst is happening. It kind of helps bring the more human aspect to things because you're able to have a conversation with them versus just seeing them during the worst time of your life, basically. Mm-hmm. So, you have an emergency or this time you don't have an emergency. It's just one thing that you needed help with. Mm-hmm. And you didn't know who else to call other than 911. And they send, the mobile integrated health unit and it brings that face. And it's not just somebody who's trying to save your life. It's somebody who's trying to make your life a little bit better. So you have that better quality of life moving forward.
I'm wondering, how do MIH programs address the needs of patients with chronic diseases and mental health issues?
All of our resources within the programs are different within different communities. I know within the bigger communities, they may have more resources for mental health, so they can kind of direct the patients into certain programs. Or right now, I know the 988 system, they're trying to get that incorporated in with MIH as well. So they help with chronic disease management by, a lot of them are getting patients their medications just because they simply can't go to the pharmacy. Mm-hmm. So they're helping in that aspect. They're making sure that, blood pressures are okay. And there's even been programs that have gone as far to get insurance for the patients. And it's made its impact within the communities, and it's awesome to see.
What role do social work and substance abuse resources play in Indiana MIH programs?
So they all kind of are within the same realm almost. So social work is kind of an aspect of mobile integrated health. It's good to have a social work background. And within the community paramedicine, there's a program that most of the mobile integrated health providers take. Mm-hmm. There is a social work aspect to it. So they're not certified social workers, not all of them. Some of them can be. But between that kind of helps with that, bridging the gap between, the substance abuse or behavioral health issues or just needing somebody else there to kind of help take care of that patient. there's a ton of social work aspects to this job. So, but I feel like social work is kind of in every aspect of healthcare, not just this side.
On a state level, how do you work to ensure that MIH programs are accessible to underserved or remote communities in the state?
So within the state, from our level, we do have a dashboard on the website, the in.gov. If you just search MIH, you can get to the dashboard, and it's very interactive. That was one of the major things that Brittany did before she left, was to make sure that everybody had accessibility to it. So if you have a smartphone, you have a computer, you have anything, you can get to a library, to a computer. You can see all of the resources in your communities. So we've just continued to add the programs. You can click by county and see, what services are available. You can see who you need to contact. They have names, phone numbers, addresses, all of the things that you would need to contact somebody. They also show all of the resources that they provide.
Are there challenges that Indiana communities may face when establishing their own community paramedicine groups?
Sometimes the things that we're seeing now are just selling the program itself, and because it's such a new aspect to healthcare that people just don't understand it. So instead of, listening and understanding it, they just say, oh, well, we've never done that before, so we're not going to do it.
Yeah.
So I feel like, coming from a smaller community myself, I know that it's hard to kind of tell people, hey, this is what we should be doing, when they've done it a certain way for, 20, 30 years. But I do feel like it's more important in the smaller communities because it's rural. You don't have as many resources, and you don't have as much access to things. And that's the population that needs it. And they're the ones that want to, age in place. They want to stay at home. They want to be there. They don't want to go, to Indianapolis or bigger cities around, and just because they don't want to do it, and they don't want to drive, they don't want to go. So I do feel like the smaller rural communities, it's harder to get into because it's a newer concept, but it's very important to get into those communities.
Are there any specific initiatives or partnerships that have been particularly successful in advancing MIH in Indiana?
There have been a lot of big programs through Indiana. I know Crawfordsville is a massive player within the state of Indiana. Monticello has done amazing things. They have run that program, and it's been amazing, and it's been accepted by the community. Crawfordsville does amazing things. Bloomington is doing amazing things. These bigger communities are more accepting, and I feel like they're able to reach out to the resources within the communities, and they've all been very big about how can we help the patient, and everybody's been very accepting of it.
I'm wondering, in your experience, how does Indiana compare to other states in terms of the adoption and success of MIH programs?
So right now, Indiana is kind of towards the top of it. It's still very new within the United States. But between Indiana and the surrounding states around here, I know Michigan is, they have a successful program. Illinois is a little bit closer to Michigan, but Indiana is towards the top of it. California is just now starting something, so they're still trying to grasp the whole concept of it. And I want to say there's a few states out west that are kind of the same place that we are, but they don't have the patient population that we do because it's not as populated out there. It's more wildlife than it is humans. Indiana is among the top of the operating states, which is awesome to say.
What is the long-term vision for MIH in Indiana, and how do you see it evolving in the coming years?
So long-term vision for the state of MIH is getting sustainability and making sure the funding is there for our programs. We're also developing the educational aspect and, what kind of certifications are providers supposed to be holding. I do see it expanding more because we continue to have multiple programs every time we meet that want to be a part of this. And I feel like it's branching out into the smaller communities like we want them to. So I do feel like it's going to be statewide. I feel like every county will eventually kind of just jump on the ship and realize that, hey, this is what our population needs. This is what our community needs. So I do see it getting bigger. It's just a matter of what can we do to get it there.
What advice would you give to everyday citizens and EMS personnel who want to get involved or support MIH efforts in Indiana?
To get involved is super easy. If you have questions at all, you can always reach out to the office or myself, Director Kinney, anybody, you can reach out, ask questions, anything and everything. There's never a stupid question for anything because it is so new. So, I mean, there's going to be the questions, but it doesn't hurt to start it. And you have to start somewhere, and it doesn't hurt to start small. Just figure out what your community needs. If you think, hey, they just need help because they're falling at home, just start there. Yeah. So if you just start somewhere, it's going to help.
Yeah, absolutely. I want to thank you for coming to talk with us today, Emily.
Awesome. Thank you.
Now let's shift our focus to the heart of Bloomington, where a team of dedicated MIH providers from Bloomington Fire Department are joining us. Okay, first let's go around the table, and if you can introduce yourself and also kind of explain what your role within the Bloomington Mobile Integrated Health Team is.
I am Shelby Vandermoor. My position is the program manager for the Mobile Integrated Health Team at the Bloomington Fire Department.
I'm Lily Blackwell. I am a community EMT and a member of the Suicide Overdose Fatality Review.
I am Amber Stewart. I am a community EMT and community health worker with Bloomington Fire Department, and I'm also logistics for the team.
My name is Trisha Rademacher. I am a community EMT with the Bloomington Fire Department, as well as a community health worker and the team trainer.
So my first question is, what inspired each of you to become involved in EMS and later mobile integrated health?
So my involvement with EMS began with a very strong background in public servants with my family. So I got to kind of carry that on with my EMT. But mobile integrated health for me, I was a part of the beginning of the program, and so it was really just coming to fruition as I started. I fell into mobile integrated health, and it perfectly suited the combination of EMT skills along with my human service background and education all in one.
I came to EMS from the fire side of things originally, and I came to Mobile Integrated Health when I realized that I had a desire to still work in the EMS field, but I wanted to know what patient outcomes were, and I didn't get to see that very often. And then the biggest part for me was that I wanted to be part of a solution to the healthcare gap.
I came into EMS. I have a big family background into public service as well. I have two uncles that are retired from Terre Haute City Fire. Also, my grandmother was a nurse. I have an uncle who's an attorney. So I kind of went through all of those things. I have a varied background in medical and patient advocacy. So kind of went through some EMS and medical stuff, decided that I wanted to kind of go through that, and then also did some fire stuff. So that's how I came into it.
Hey, I came into EMS because my mother was a nurse forever, and I was going to follow in those footsteps, and it just didn't really fit. But EMS did, right? So I pursued that career path, became a primary instructor, and it was through that primary instructor role that I learned about mobile integrated health. I had to teach it, right? So I had to do some research and got super excited and figured out really quickly that that's where I needed to be. So I was super fortunate to have this program in place right where I live. So that's what got me here to MIH.
How has MIH changed the way you approach patient care compared to traditional EMS roles?
So in my traditional EMS role, right, I would run to the 911 call, and we would take care of that patient. We would transfer care at a, definitive care in the hospital setting, and then I would be on to the next. It was kind of this love them and leave them thing, right? Mm-hmm. I don't have to do that now. Right? So once these folks get sent home from the hospital to rest, recover, rehab, whatever that looks like for them, I get to be that person that helps them navigate the what's next. And that's just the most rewarding end of this. I feel like my role as the EMS provider on that emergent ambulance was super important, and those folks are working with shortages, right?
Yeah.
we don't have enough personnel, but I get to help them out. So by being able to get in there and meet these folks when they're doing their best work at home, resting, recovering, rehabbing, I get to fill the gaps and keep them hopefully out of the back of that ambulance, keep them out of that hospital bed, and provide those two systems the respite that they need to have an empty bed for a critical patient.
Can you share a memorable experience you had where MIH made a significant impact on a patient's life or health outcomes?
One of the biggest ones for us that has made a significant impact. I will share with you that a patient, our team was responding with the mobile crisis team through Centerstone, which is also stationed at our Stride Center here. So we had responded with mobile crisis to do a health assessment because they were there checking on this gentleman's mental health. When I came in to see this gentleman, it was very clear that he was very, very sick. And unfortunately, he was not willing to really accept help at that moment. So at that time, I was human service professional number 11 to respond to this gentleman. For some reason, he let me come back. What was really cool is I went back a couple days later, and when I walked in, I said, "Hey, I really need you to go to the hospital with me." And he looked at me, and again, he's always declined cares. He sent away EMS, and he said that he would go with me. And when I got to the hospital, it was a really big deal, right? But the thing with this gentleman is when I found him, he was in a unfinished garage, and it was really, really cold outside. And a local gentleman had allowed him to stay in that garage just so that he wouldn't freeze to death. Mm-hmm. This patient had been unhoused for 9 years, right? No forms of identification. Mm-hmm. Couldn't really tell you his date of birth, definitely didn't know his social security number, anything like that. So we get him to the hospital, right, but we have no form of identification and we have no Medicaid or anything like that. They do admit him, and I go home for the night, and I get a call from the physician that evening that they had to do emergency surgery on him, and he would not have lived through the weekend. So that was a really big deal. But that was just the beginning for this gentleman, because the hospital did their job. They saved his life, and then once he was done, he was discharged from the hospital and right back to where he was, because he didn't have insurance. He didn't have the things that he needed to be able to long-term help him. Mm-hmm. So, as I said, he had no identification. So I worked with the state health department to get his birth certificate, which was really difficult, I will tell you. So we worked to get his birth certificate, and then we eventually worked to get his social security number and his social security card. So then he got Medicaid, and currently is in a long-term care facility receiving what he needs. One of my favorite parts about all of that, though, is that care facility. Again, for some reason, this gentleman let me come back. Mm-hmm. He didn't let anybody else come back. That care facility now, when he's not taking his medication or being a little sassy that day, that care facility calls me and says, "Hey, can you come see him?" Mm-hmm. And it always helps. So for us, his quality of life definitely improved just because mobile integrated health existed.
What types of services does your MIH program offer to patients in need in Bloomington?
Our program covers 4 main areas. The first is to do with falls and lift assists. The second is mental health and substance use. The third is what we call healthy living, and it's kind of all-encompassing, so that if you don't fit in the other ones, we can surely help you, that last one. And then that fourth one is maternal and infant health, where we're really focused on preventing infant and maternal mortality. So when we talk about falls and lift assists, they were ones that when we first came on with our program, they were identified as our easy wins. And we learned really quick that in mobile integrated health, there is no such thing as an easy win. But we did learn that our falls and lift assists for us were super easily identified, because Bloomington Fire, they respond specifically to falls and lift assists. Mm-hmm. So when that's dispatched out, that's easily caught of, okay, we're running to this specific address over and over again for a fall or a lift. So those were ones that were really easily identified. And our goal was to go in and figure out why people were falling, right? Was it because the home's unsafe? Was it because our health was declining? So we go in and we look at, okay, how can we prevent the falls? And then overall, what can we do to keep things safer? And we do home safety checklists, including fire prevention things. Do we have working smoke detectors? Do we have fire extinguishers, which we know people don't, right? We're identifying that every day. So that first area with falls and lifts, they're really easily identified. That is where we get referrals daily with falls and lifts because they're so easily identified. Also with that, we realized how heavily populated the Bloomington population is with elderly, right? So we were finding our falls and lifts, we are specifically helping our elderly population, people that are scared to ask for help because they don't want to go into a nursing home. And so they're not asking. And then it's getting worse. And our goal always is to help people age in place. If they want to be home, we want that for them. So we're going to figure out holistically how we can make that happen. With mental health and substance use, it's really one that we're seeing, especially with mental health. A lot of times if we're there for a medical call, we know physical health and mental health go right hand in hand. So they're pretty easily identified. When we go for a medical follow-up, we are easily identifying that somebody is having a mental health issue. We are not social workers and we're not crisis counselors, so we have the opportunity to pull those in with us from our local police department has social workers, and then we work closely with the STRIDE team, the crisis team through STRIDE with their crisis counselors, so that if someone needs that sort of mental health help, that we can get that. We can also make referrals to different organizations. We are connected with different facilities if someone's needing treatment. We have good working relationship to get people admitted into places. With healthy living, we're really trying to prevent hospital readmits, right? So we know that takes a huge hit for our health care, right? So if we can prevent a hospital readmit, we want to. If we can address things like chronic disease, we've got people that are diabetic that aren't taking their insulin because they can't afford it, right? So they're rationing their insulin. And then we're going into their homes and realizing these people are dying, right? So we're able to identify that, and on more than one occasion, worked with our township trustees to help get insulin paid for so that our diabetics are not taking their insulin. And then our maternal and infant health, focused on maternal and infant mortality, preventing that. That was something that we planned on developing over the next couple of years, but then it fell into our lap about a month ago after our crews had delivered a baby on site. And so we didn't anticipate being ready for that version, but I can tell you that I'm incredibly grateful. We just recently went through a perinatal mood disorder intensive training, and like we talk about mental health, that is such a huge part, and pregnancy and post-pregnancy, our bodies are so different, and then we're expected to take care of babies, right? So we definitely need those extra supports.
Could you describe the role of telehealth in your MIH program and how it benefits patients?
So we've done telehealth with several patients, and it has allowed us to do things such as providing vitals, and we can listen to the breath sounds for the patient before they see the doctor on their telehealth visit. And it also, allows us to do a physical assessment and provide those details to that provider. And we can also help the patient during their patient interview, especially if there's information we know that maybe is just not coming to mind during that interview, but we've talked about it with them in the past. We can remind them, this is going on, or, don't forget to tell them that you are diabetic.
You're like an ally in the room.
Yes, and helping them advocate for themselves during that appointment. And one of the patients that we saw through we assisted them with a telehealth visit. She was able to do it from in her home, which she didn't want to leave and was not able to leave. We were able to get her seen 2 weeks earlier by a provider than she had already been scheduled to go in office. And they prescribed her necessary medications, got her orders for her home health, which she desperately needed, and for physical therapy to try and get her back on her feet.
What challenges do MIH providers face when coordinating care for patients in their home or in mobile environments?
There's a lot of different varieties of things that we face. Sometimes that's getting in touch with providers like the primary care physicians. Sometimes it's finding the patient. Sometimes our patients, we meet the patient where they're at. So sometimes that varies from day to day. That can be a barrier. But usually we're very determined individuals, and we don't give up easily. That's kind of one of those things where we're like, if that means we have to go knocking on your primary care's front door, we're going to go knocking on your primary care's front door. We do what needs to be done so that way they get the care that they need, and somebody's that voice for them that needs to happen.
How do you ensure that MIH services are accessible and inclusive for all members of the community, especially underserved populations?
Yeah, so something that's really cool about us being a part of the fire department is we are really able to easily identify what the needs are because we're being called to those whose needs need to be met. And we're designed by the city to be able to change and evolve with the needs of the community. So I think that's really important for us as healthcare providers, that this is what we do, right? So our goal is to serve all, but especially not forgetting our underserved population. We are, as members of the city of Bloomington, along with all of the education that comes from our trainer, we are really striving to be culturally competent. That also means for us that when we go into situations where we don't necessarily resonate with them, it is important that we connect them with people that do. So, for example, we have a previous patient who came to us of Native American descent and had been sex trafficked. Really rough situation. I am not going to pretend that I understand what she's going through. And there was not anybody on my team at the time that could understand what she was going through. I had to find her the right resources, especially culturally, of people that were going to understand how she was feeling. So I know for us, we didn't actually have, we have a plethora of resources here in Bloomington. We didn't actually have something specific for her. So I can tell you that our team scoured the state for culturally competent resources for her, and we found them. So what's really cool is now we can be very loud for those specific resources. But what might work today might not work 6 months from now. It might not even work a month from now. But we are willing to be learners and good community partners and good really providers, healthcare providers, so that as needs change or demographics shift, we're able to shift to meet those needs.
Can you elaborate on the collaboration between MIH teams and other healthcare providers or agencies in your area?
Yeah, so I am a huge advocate of teamwork makes the dream work. I know that's very cheesy, but when we began the program in last October, this was so new. There's nothing like us around us, and we were number 27th approved in the state. So there wasn't another mobile integrated health team right by us that we could lean on that was understanding where we were coming from, right? So there's definitely other community paramedicine teams and MIH mobile integrated health teams in the state that are helpful, but it's our people in our community that are going to get it, and we are serving the same people. So it has to be a teamwork. I can tell you, for us, our healthcare providers locally have been fantastic. They understand the importance of collaboration of care. They understand that it takes a true village to take care of somebody, and that we continue to plant seeds and water other people's seeds, and hopefully that will stick. Also, other agencies in general, even if they're not healthcare providers, for us, like I said, we get referrals from everybody. And so we might get a agency. For us, a huge one is food pantries. They are huge. They are a big gift. If I am not somebody that they can call when they've got somebody that they're concerned about, then I shouldn't be able to call them, right? Yeah. We are excellent at both understanding that and always being transparent and good partners for each other. We are super lucky here in Bloomington.
How do you handle situations where a patient's needs extend beyond medical care, such as mental health or social services?
So Shelby kind of briefly talked on it earlier to kind of reiterate the fact we're not social workers, but we can identify those needs, right? We have all been in medical and in the patient advocacy world long enough that we can see those things. So we work very closely with the mobile crisis team with Stride, and that good relationship there allows us to be able to reach out to them and say, hey, we noticed this kind of thing, that kind of thing. Or even if it's other things that we're noticing, other parts. So we're able to identify those things and reach out to our partner communities for that.
I'm wondering how your MIH program addresses the management of chronic diseases among patients.
So one of the ways that we do that is assuring access to things such as insulin, and then continuing to assure that they're compliant with those medications. And part of how we do that is our follow-up visits with the patients and continuing to come back. Sometimes it's a financial barrier that needs navigated through. And we've been able to work with township trustees to get vouchers for individuals that can't afford their insulin. Another way is that we'll make referrals for medication management through various community partners, but we have been really good at finding those resources for people, I feel. And another way is that we help them establish or maintain their visits with their primary care provider, because we can't prescribe the insulin. We can only help them access it once it's prescribed. So helping them get it prescribed, helping them get it, and then helping make sure that they're taking it.
I'd love to know, what are some of the most rewarding aspects of working in MIH? And can you share any success stories of patients you've had who have greatly benefited from MIH services?
I think for me, the most rewarding aspect of this path, right, is the relationships. Okay, and over the 6 months almost that I've been here, I have grown my family, right? Whether that be my IDHS folks, Director Kenny, Dr. Yazel, Emily Castor, who I cannot say enough about, right? Or my fire folks. But ultimately, it's being able to ride these experiences with my patients. I see it as far as they'll let me see it through, right? That is the most rewarding, is just being there, being present, and building those relationships, no matter what they are. The patient that I would love to share with you is a sweet little couple. They're in their 80s. Because we know that, again, we on this recover and rehab at home, right? Because that's where we do our best of those things. Our sweet patient was taken home, newly in a wheelchair. Sometimes we don't know our limits, right? When we're new to a diagnosis. So he was being dispatched a lot for falls, right? So we were going to pick him up off the floor. So we went in and we discovered a very tired care provider. His wife was there. So not only was she wearing this hat of loving wife, taking care of a newly diagnosed husband, but she also has these 2 special needs sons at home. and they're in their 50s, but they're super active. They both have jobs, and they both compete in Special Olympics types activities. So mom was torn, right? She was like, do I stay home? I can't really do these things with the boys because I've got to stay here and take care of dad. So we were able to get in there and fill the gaps, right? These guys just needed some nudges, right? So we connected them with some of the incredible folks that we have at our fingertips here in Bloomington. That's people like Ageless Transitions, Area 10 Agency on Aging. There was a whole laundry list, right? Right down to a handyman because they needed some things done. So we connected them with that, and then we connected mom with a provider that would come in and provide the respite that she needed, not only to get out and just do errands, but also to be able to attend the Special Olympics that her sons were being participants in. And she didn't have to worry. She could leave home and not worry about her husband. So that was so satisfying to know that we not only impacted that patient, but also the care provider. And the cherry on top was the fact that they were so satisfied with the things that we had done for them and gotten in place that they referred their neighbor who, sweet little man, had a fall, and they were like, you need these people. Here's their phone number. So just that kind of interaction was very, very satisfying.
For me, it's getting to see the progress that patients are making, and especially from where we start and first meet them to where they wind up, and getting to celebrate those successes with them, big and small. And then it's also just really rewarding to let somebody out there who, a lot of our patients feel like they've just been left behind by the healthcare system. And it's rewarding to come in and let them know that they're not forgotten and they're not a lost cause and that we're there to help them. So one of my favorite stories is one of our patients is a gentleman that we were first referred to him from the emergency department. And there was some concerns that he was coming in frequently and that he was possibly intoxicated when he was coming into the ED. He also is unhoused with dementia, and he has a traumatic brain injury from early 90s. And he is also currently facing criminal charges for trespass at the garden shed that he resides in outside of his former family home. In addition to the emergency department believing that he was intoxicated, it was also identified that some EMS crews thought that he was primarily seeking pain medication by calling for services. Since we have been seeing this individual, we've connected him with a food pantry and Health Now, like I had mentioned previously. Their nurse practitioner came and did a full evaluation and was able to prescribe him necessary medications and gave him a formal diagnosis of Parkinson's disease, which he's now been able to take medication for, and it's resolved a lot of the symptoms and pain that he was calling an ambulance for prior. Our documentation's been used, and working with HealthNet as well to keep him out of jail. We've been able to attend some of his court dates, and as of yesterday, there was a warrant for him that has been rescinded. So that's a really exciting win right now. On his birthday this year, we brought him some cognitive games because he loves math and loves numbers. And then the highlight is that he hasn't been back to the emergency department since we initiated contact in April.
So my particular patient, she was calling 911 for what it would come out as was an allergic reaction. She had some chronic kind of tongue swelling issues. Also, she would kind of say some things like she was having difficulty breathing, chest pains, kind of throw some of those in there. But she would always sign what we would know in the EMS world as a SOR, so that's a signature of release. But so she would never transport from her home. She would say, I don't want to go to the hospital. So when we made initial contact with her, we started to kind of dig a little bit deeper into her and say, okay, what's really going on here? Come to find out, she had lost a significant amount of people in her life very quickly, and it was almost like she just needed somebody to come in and just kind of talk to her. She had a lot of things going on at once. So we were able to connect her with some mental health resources, also connect her with Area 10 because she was having a hard time trying to clean up her apartment. And get that ball kind of rolling with her. Also, keep in contact with her every week. She also has at that time, she had an estranged son. She ended up kind of telling me the story about how with her estranged son that the reason why it became like that was because she was not taking care of her medical needs. And because we kind of stepped in and helped her through that process, that she was able to rebuild that relationship, and her estranged son was like, great, I see that. And so she now has this relationship again with her estranged son. She's getting to see her granddaughter again. She's getting to do those things. So she's seeing the positivity coming out of that, all because we were able to kind of come in and just check in with her. She has a renewed trust in the healthcare field because of what we do. And she says that when you talk to her. And it's a great individual, and it's a great thing to be able to do that for her.
What training and qualifications are necessary for EMS professionals to transition into MIH roles effectively?
So for our program, okay, the minimum entry is that basic EMT. Okay, and then you kind of need this advocacy background, and then you will go through the paces of a community health worker certification level, as well as the mental health first aid. And we're working toward, actually, Shelby and I are working through our certification for the perinatal mental health, as she had mentioned previously. We are also super lucky that we are starting to train as CPR instructors, so we can take that knowledge out to the community, because we know rapid CPR, right, leads to better outcomes.
Yes.
So we've got that kind of stuff in place, and as we grow and our vision starts to change a little bit, our education is going to grow with that. So not sure what that's going to look like yet, right? But the growth is coming, so we're going to prepare.
What are some of the best practices for building trust and rapport with patients during home visits or mobile encounters?
Well, my goal as a community EMT, right, in this role, is I want to make your life better at least by 1%. If I can do more, I'm doing the more, right? I think just the building of the rapport, we have this instant rapport, honestly, because we're part of the city of Bloomington's Fire Department. We're so trusted and looked at so favorably. They're opening their doors. But beyond that, I think that rapport is built because we're consistent. We show up when some of these folks have just not really had anybody do that for them. And we lend them the voice that they really need when they need it.
Are there any specific technologies or tools that have been particularly helpful for your MIH program?
Yeah, so definitely telehealth. That has been really a remarkable change for a lot of people, because we do see a lot of people that are homebound, and not just from quarantine during COVID-19, they previously were or they are now, and just continuing that system of care that was really fundamental during the past few years. Another tool that we use frequently is our own fire prevention officer. We go into homes where there aren't working smoke detectors or extinguishers, and fire prevention is able to come and provide working smoke detectors to those homes, which gives peace of mind to everybody, if there's an emergency. Another tool that we rely on frequently is food pantries. A lot of people's healthcare needs, they really start at needing food. And, a lot of our own nutrition, just that's where it comes from. So being able to provide food to these people and their most basic needs so that we can focus on their larger needs after that. And one team that we work with particularly is HealthNet, and they have lots of services that are available for unhoused or lower income individuals, those that don't qualify for Medicaid, and they're just a tremendous help to us.
What advice would you give to EMS professionals who are interested in transitioning into MIH roles?
So basically, do the right thing. Always come in and have a positive attitude, and understand that the community EMT or community paramedicine is a little bit different than what our traditional roles in EMS are. It's not about yourself. It's about the patient. You put that patient first. You truly have to look at this as, what would you do if that was your family member? And you really have to love them as if that was your family member. Give them the same courtesy. That means being on time, doing all those things, and showing them that same patience that you would as if that was your loved one, if that was your grandmother, your grandpa, your cousin, your sister, your brother, your friend. Coming in and just letting them know that you have to come and really have that giving and caring, loving heart to know that you want to do this job. And also continuing to be that lifelong learner and know that you are always going to learn something new. You don't know everything. Mm-hmm. That's the same thing in fire too. That's the same thing we get preached in EMS. You don't know everything, and always be willing to learn something new every day.
How has MIH enhanced the integration of EMS into the broader healthcare system in your area?
Yeah, so I think it's really cool for us because we're uniquely positioned as mobile integrated health, especially within the fire department. We are gap care. So it has been great as far as, our EMTs and paramedics are they're running, right? And then they're doing what they're supposed to do and getting them to where they need to go. But then they get dropped back off, or what happens then? Yeah. So from there, especially if we have a patient that we've identified while we are on scene, what's really cool, we had one yesterday, for example, that we had to call 911 for. We were able to walk through what we knew with the emergency department. So we were able to be the in-between for those two. And then now that that person is being released, we can follow up from there and fill that gap in between when they go back to primary care. So it's a really natural gap. Mm-hmm. I think at first it doesn't feel natural, right? Because we are an in-between, right? So we're not running emergent, mm-hmm. right? But we are all EMTs. Yeah. And we have the same skills, but we're not running emergent, and we're not transporting because we're BLS non-transport here at Bloomington Fire. What now? Mm-hmm. Right? We actually are perfectly situated to be that gap in between all of these other different stops.
I'm wondering, in your experience, how does MIH contribute to reducing non-emergency 911 calls and optimizing resources?
So that would be by identifying those super users or those people who call 911 frequently. Our firefighters are really good, really, really good about stepping in and saying that we think that this might be an issue, or something doesn't seem right. They are very good at trusting their gut, and they report it to us, and we're able to get to it and say, okay, let's step in and see what we can do. And we see that, and the guys see that. The guys see, and they report back to us like, thank you so much for that. So, and also our community partners also say the same thing.
Can you share any data or statistics that showcase the positive outcomes or cost savings associated with your MIH program?
Yeah, so our program received its 100th referral to the program in August of this last year. So that was really big, especially before a year. Yeah. So at any point in time, we have about 46 open patients, which is a pretty heavy load, I will share. We see patients on average of 6 times, so that's really important for us because we are not just I'm going to see you one time and then walk away. We are knowing that the population we serve, people need them to show up.
Yeah.
Right, so we're continuing to show up for them. Cost savings associated with that. One thing that's really big to know, it's an expensive thing for a fire engine or a fire truck or ladder truck to run, right, to an emergency. We are able to not only keep those crews in service and those trucks in service, but we're saving that cost and preventing them from having to go make those calls that they don't necessarily have to.
What impact has the legislative support for MIH had on the development and sustainability of your program?
All right, so legislative changes are directly responsible for allowing the creation of and providing funding mechanisms for mobile integrated healthcare in Indiana. As they continue to evolve, there will be several opportunities to leverage local dollars to obtain state and federal funding to vastly improve the vital services we provide. What's really cool too with our state in general, our state is really gravitating towards supporting these programs. They're seeing that it's working, right? So they're taking the time to invest in it. And we obviously are celebrating mobile integrated health as the state of Indiana. So we are very much supported in what we're doing, and I cannot wait to see how that continue to grow.
How do you see the future of MIH evolving in your region, and what are some challenges or opportunities you see that lie ahead?
So mobile integrated health specifically in our community, I can tell you, is going to be able to grow next year. We'll be able to add 3 more people to our team, which is a really big deal. I think it's really important that people and communities are leaning on the mobile integrated health portion of IDHS because that's who really governs what we do, right? So, and if people are looking to grow programs, which it's absolutely necessary everywhere, I cannot begin to explain how important it is everywhere, and how much of it is an answer to what we're doing. But I can tell you for us, we're really a part right now of creating a set of standards and procedures and what mobile integrated health looks like, because we're part of those trailblazers because it's so new.
Yeah.
Right? So everything that we're getting to do, we're kind of helping to write a rule book. And what's really, really great is Dr. Yazel and Dr. Kinney and Emily Castor, the Mobile Integrated Health State Coordinator. All of those people are so present with us that this is something that we are able to evolve and grow, because once we know better, we do better, right? So that looks very different for each community, but I know specifically for ours, it's going to be really beneficial.
How can everyday citizens get involved and support MIH efforts in their communities? And where can listeners go to learn more and connect with your MIH program?
So it's really simple. If you see something, say something. That's not so much as like we're saying call 911 to get a hold of us, but we are really accessible to you. And we want those people who, if they see their neighbor is like, for instance, she had already mentioned before, her patients really loved the service that we provided, so they were like, hey, we have a neighbor who might benefit from you guys. We get that a lot, where we have some people who are like, maybe our neighbor, we've noticed that the ambulance has been at our neighbor's house a lot. Definitely say something to us, because we would be glad to go by and say, hey, what's going on? They don't have to know all those different things as to why we're going by there. But yeah, if you see something, say something.
So other things that citizens can do just every day to help support us. One of the really cool things that, we mentioned being CPR instructors. If you have somebody that, you have a business, right, or a community that needs a CPR class, remember that we're here. We are community EMTs. So we're here to serve the community in whatever capacity they need. Another really cool thing that we do, we run a lot of first aid booths, right? So because we're all EMTs, we have the ability to do that. So if you have an event where within the city that, it's a public event. We just did the walk to end Alzheimer's this last weekend. In a couple weeks, we have the buddy walk at Switchyard Park. And that's really cool. So we have that ability to do those things. So remember us when you do events or, have programs or that sort of thing. Another really cool thing is that you can always make monetary donations to our program specifically, and we can answer any questions that you have about that. You can just call our fire department directly. But what's really cool about donations for those sorts of things, because we're uniquely positioned to see needs of people, for example, we're seeing, especially when we're going into homes of elderly, that they don't have fire extinguishers. Right? They don't have fire extinguishers. They don't even have a way to go get one, and they don't have the money to get one. Yeah. Right? So, for their safety, we don't want to look the other way, right? So things like donations and that sort of stuff, that can help us provide those things. So that's huge. One of the big things is if you see us in the community, just come see us, right? If we're a part of several speaking events, come listen to us talk. Give us a call. Right, but one of the really cool things that you can always find updates for us. We are featured often on the City of Bloomington, Indiana Fire Department Facebook page, so you can get any updates with us there. You can also call our Fire Department administration line. That number is 812-369-1171, and they can get you with a mobile integrated health team.
With it being MIH week when this episode comes out, is there something you hope Hoosiers get out of the week, or any final thoughts you'd like to leave us with?
I think one thing specifically I hope they know is we want to help them age in place. That's a huge fear for people, especially with our elderly. But also, if you think somebody needs help, don't wait. Because the longer you wait, the worse the situation's going to get, and the harder it is to reach those outcomes that we're hoping for if we can, right? So don't wait. If you think a neighbor needs help, if you think your mom needs help, if you need help, just call, right? We're going to figure out what it is. There's no direct answer for anything specific, but nothing is too weird for us. That sounds crazy. I think that's an EMS world in general. It might be a first for us specifically with mobile integrated health, but it won't be the first ever in the world, so don't worry. But we're here, and Indiana has set us up to take care of people. Let us take care of you.
If your listeners are listening outside of the area that we serve, I hope that they see the need and they speak to somebody, say, hey, we need this kind of service in our area too. And I'm speaking for Shelby, but I know Shelby's heart. If they see the need and they want to start cultivating this kind of a program in their area, call this girl. She's grown this from its infancy to what it is now, and it's limitless, right? So that's what I hope that they get from the presentation.
I'd just like to let listeners know that if you are willing to trust us, we're willing to invest our time with you, and we want you to succeed and to be healthy and have a better quality of life.
You're okay. Thank you for joining us on this insightful journey into the world of mobile integrated health. Today, we've learned how MIH is transforming healthcare delivery in Indiana, from the strategic planning at the state level with Emily Castor, to the hands-on experiences of our passionate MIH providers in Bloomington. To learn more about mobile integrated health, visit on.in.gov/MIH. There, you'll find a wealth of information, including a comprehensive dashboard where you can see all the strides Indiana MIH programs are making, as well as how your department can set up an MIH program for your community. Thank you for listening to Hoosier Homeland. This podcast has been a production of the Indiana Department of Homeland Security. If you've enjoyed this episode, our full catalog can be found on Spotify, Google Podcasts, YouTube, and Pandora. To listen to previous episodes, go to on.in.gov/Hoosier Homeland. You can follow us on Facebook and Instagram at Indiana DHS and on Twitter at IDHS. We will see you in our next episode. Until then, stay informed, stay prepared, and take control of your safety.